Rehabilitation. With me today is Sal, our volunteer male model, so we wanted to thank Sal for joining us today. I've been asked to describe with you the upper limb extremity examination, screening examination, as well as the spine examination. Before starting out, though, with any physical exam maneuver, it's very important that you appropriately wash your hands. So I'm going to head over to the sink here. It's a good idea to use hot or cold water. Basically, you just want to try to create some mechanical disturbance so that you can clean the skin and prevent the spread of infection. So that's an important point. I think it also reinforces to the patients that you use proper hygiene prior to the examination, so I think that's another important point. When I get started for the physical examination, after I've taken an adequate history, I like watching the patient disrobe. So I'm going to actually have Sal in a male disrobe so I can really get a good look at his upper extremity, both function as well as anatomy. So Sal, go ahead and do that. In a woman, sometimes it's easier for a woman maybe to partially, obviously, gown them, so where they might have one hand in the garment and you can tie up the robe back like this. I also find that in younger female athlete patients that sometimes a training bra is helpful to do an adequate examination. But for Sal, being that he's a male, we're going to allow him to completely disrobe for the upper extremity examination. Before I also start, I just wanted to highlight some important planes of motion, which are all planes that we move through, and sometimes it's missed on examination. Particularly when you're describing this to a colleague, you can describe to them a particular plane of motion. The three planes that we highlight are the sagittal, coronal, and transverse planes. The sagittal plane is any motion that occurs in front of the body or behind the body in 90 degrees of motion. So this would be considered shoulder flexion, for example, or a sagittal plane motion. The second plane would be coronal plane, or sometimes referred to as frontal plane motion, and that's anything that's in the plane of the body. One way to remember that would be to look at the sutures of the calvaria. The sutures have similar names, so the sagittal suture would be one that's running directly down the middle of the cranium. The coronal suture, which is running in a 90-degree fashion to the sagittal suture, is another way to remember those planes of motion, so the sagittal and coronal. The third plane of motion is a transverse plane, or also goes by axial plane motion. That really involves any type of rotational motion. So if you talk about transverse plane motion through the spine or hips, it's kind of like your twisting motion, or if it's at the shoulder, internal and external rotation, which we'll highlight in a minute, also is a transverse plane motion. The next thing I do is, with any part of the physical examination, orthopedics and rehabilitation, is to start out with inspection. So we're going to start with Sal's hand here, and we're going to look at his nails first. With nails, you can pick up a few things that describe systemic pathology as well as arthritides. For instance, splinter hemorrhages sometimes can indicate subendocardial bacteritis. You could also have hemorrhaging, which may be from trauma. Also clubbing, which may result from pulmonary disorders. And then conditions such as I treat, which are spine conditions, pitting, such as in psoriasis, can sometimes lead to nail abnormalities. And psoriasis can lead to potential arthritides or different types of arthritis. The next thing would be to inspect the palms. And really, when we're talking about the palm, we're talking about the thenar eminence, which is on the radial aspect of the hand, as well as the hypothenar eminence, which is on the little finger side or ulnar aspect of the hand. So it's the hypothenar and thenar eminences. The next thing would be to look at the skin. And really, you're just looking for abrasions. For some patients, particularly patients who may be on steroids or those types of medication, they may have thin skin. You're looking for ecchymosis that may be associated with trauma. The other thing is to look at individual joints. And in the hand, we're talking about the distal interphalangeal joint, or DIP, the proximal interphalangeal joint, or PIP, and then you have the metacarpal phalangeal joint, because the metacarpal bone is this bone and the phalanx is this, so you have the metacarpal phalangeal joint, or MCP. So those are basically the three articulations of the fingers. You can move back proximally to the wrist, and you will have the carpal metacarpal junction, and these are filled with your carpal bones, and there's both a proximal and distal row. The other thing with looking at overall in terms of inspection would be to look for things such as fasciculations, atrophy, or any other types of deformities which may be important. Scars, which may have indicated previous trauma, as well as past surgical history, is also an important key point to check for. The next thing that sometimes that you would want to check in terms of hand examination and wrist examination would be pulses. And in the wrist, you have both the radial pulse, which is one that I think we're all pretty familiar with checking heart rate, as well as the ulnar pulse. And you can appreciate both of those. The ulnar is sometimes a little bit more difficult to appreciate as it sits a little bit more deeply. The next thing would be to pinpoint specific anatomic landmarks, and one of the most important ones in the wrist is what's called the anatomic snuff box. The anatomic snuff box represents one of the important carpal bones, which is your scaphoid. Sometimes that's fractured. Say, for instance, a young person who's skateboarding falls on their hand may fracture their scaphoid. And the way that you want to find this landmark is you want to have the patient extend their thumb. And basically what you're looking for is a little dimple that occurs on the dorsal radial aspect of the wrist. And it sounds not as prominently. I'll demonstrate on myself. It may be easier to see. You can see there's a little dimple that's created right there, and that's really the location of the scaphoid. And sometimes tenderness in that area may indicate, particularly in the setting of trauma, may indicate a fracture. The next thing that we were going to go on to is describing different types of tendinous structures that may be present in the wrist. And on the volar side of the wrist, which is the palmar aspect, palmar and volar essentially mean the same thing, you want to look for different tendinous structures. So there are wrist flexor tendons that are on this side of the wrist, whereas on the dorsal side of the wrist, you will have the wrist extensors. The other important thing are looking for other bony prominences, such as the distal ulnar styloid, which would be on the dorsal aspect of the wrist, fairly prominent bony structure, as well as the radial styloid, which is on the radial aspect, dorsal radial aspect of the wrist. And you can palpate both of those structures. The next thing we're going to do is move up. Now, the elbow has very important articulations. It has basically a range of motion that basically has flexion, which is anywhere to approximately 130 degrees. You can have full extension, okay, which is, again, these are sagittal plane motions because they're occurring in this plane of the body. In women, sometimes they may be a little bit more lax and they might have increased extension through the elbow. They may have anywhere from -5 to 10 degrees. Not an important point, but something just to realize that women may be a little bit more lax than men. The important bony structures to also highlight at the elbow would be the olecranon process, which probably can be best seen by having the person bend their elbow. Clinically, this sometimes may be involved in terms of a traumatic olecranon bursitis. Somebody falls onto the elbow, may be developing some significant bursal swelling here. The other important structures are the medial epicondyle, which is the distal aspect of the humerus, which is here. This acts as the origin of the wrist flexors, and sometimes that's involved with what people euphemistically call your golfer's elbow, the medial epicondylar or wrist flexor tendons. On the outer aspect, you'll have the lateral epicondylar or wrist extensor structures, and you can palpate this as a bony prominence here. One other motion that's sometimes not described with the elbow, but more with the wrist, would be pronation and supination. Pronation I really think of as when the palm is turned down towards the ground. Supination is when the palm is turned up towards the ceiling. And you can really highlight this when you have somebody bring their palm up. Sal just demonstrated for us there finger extension, something I failed to mention in range of motion, and then finger flexion, which is again sagittal plane motion. If he opens his hand as such and he spreads his fingers apart, that's referred to as finger abduction. And finger abduction, B as in boy, is in reference to the long finger. So anytime you have coronal plane or abduction of the fingers, they are in reference is when he brings his fingers towards the third finger. So that's abduction away, and then adduction towards. So let's go back to the elbow joint. We highlighted a couple of things. Pronation, once again, palm down. Supination, palm up. You can see some of that motion occurs at the wrist. Some of that motion occurs at the elbow. Now we're going to turn our attention up to the shoulder joint. I think the shoulder joint is probably one of the most complex articular structures in the body. There are some important bony anatomy that we need to highlight. First would be the clavicle, and the way that I think most people are familiar with the clavicle, as we used to call it the collarbone, is just feeling the bony prominence that's sitting just above his pectoralis muscle. You can feel that and see it fairly prominently. And I typically will start palpating that and go medially towards the midline of the body, and this actually is what connects the upper limb to the axial skeleton, and this is through what's called the sternoclavicular joint. Sternoclavicular joint is located right about this area as you march your way along the clavicle to the sternum. As you march laterally, you'll come out to the acromioclavicular joint. The acromioclavicular joint is actually felt to be like a knuckle that you'll feel at the end of the clavicle. And the acromion is actually, if you think about it, actually part of the scapula. So the scapula articulates with the clavicle, which articulates with the sternum, thereby linking the upper limb to the axial skeleton. Okay? The other important structure that's sometimes difficult to appreciate in a robust individual such as Sal here, is a pretty strong guy, is the coracoid process. The coracoid process, the best way that I think to feel it sometimes is really to feel the acromion and then sometimes march your way down just below that area, maybe a few finger breaths, and you'll palpate in this area. You notice he winced because typically the coracoid process is a little bit tender to most patients. So it's not necessarily pathological, that's just sometimes the coracoid is tender like that. And again, in bigger individuals, it may be difficult to palpate that structure. The coracoid is important because it acts as an origin for your biceps tendon. It's the short head of the biceps, and the long head of the biceps actually comes from within the shoulder. The long head of the biceps goes through two tuberosities known as the greater and lesser tuberosities. These tuberosities are very difficult to palpate in a lot of individuals. Once again, Sal has a very prominent deltoid, so it's difficult to appreciate that. One way that I find that might be easier to feel is if you feel just below the acromioclavicular joint and move a little lateral. I sometimes put my hand in that area, and then I might have him just rotate his shoulder in and out. And sometimes you can feel these bony prominences a little easier. Again, they're very difficult to appreciate. The lesser tubercle is more medial, and the greater tubercle is more lateral, and in between is the long head of the biceps tendon. The other key factor with shoulder is talking about asymmetry, and one of the key factors with asymmetry is looking for atrophy. And frequently I will look at the atrophy of the shoulder of the deltoid, but more importantly is looking at the scapula. So Sal, let me just have you go ahead and stand up if you don't mind. And I'm going to have you turn around and face the wall for me. Okay. I'm going to switch to his right side. When we're talking about scapula, the important things to look out for here are, number one, both inspection and on palpation is the spine of the scapula. And the spine of the scapula can be appreciated as a bony prominence that is somewhat medial and then courses lateral out onto the acromion. Above the spine of the scapula, you have a prominent rotator cuff muscle above the spine known as the supraspinatus, and that would be located right around this area, the supraspinatus, a very important rotator cuff muscle. Below the spine of the scapula, you have the infraspinatus. Below the spine, infraspinatus. It is an external rotator cuff muscle. When we talk about, go ahead and turn around for me again, Sal. Other planes of motion that we need to highlight are at the wrist. If we can go back down to the wrist, would be particular range of motions that we should talk about in terms of total degrees of range. And the numbers aren't really as important as just to get a sense of what is normal range for that individual patient. And a really key component of this, I think, is always to compare range of motion to the opposite side. We always have a saying in medicine that God gave us two so that we can compare one side to the other. Really, when we talk about wrist, we're talking about the sagittal plane motion of flexion as well as extension. So that would be flexion down to about 90 degrees, and extension is a little bit less, to about 70 degrees. We also have what's called radial deviation. Radial deviation is when he would bring his wrist or his thumb closer towards his body in that plane, and then ulnar deviation is out about that way. I can demonstrate that a little bit better if we let his hand drop down to his side. Radial deviation, when he brings his thumb towards the body, is about 20 degrees, and then ulnar deviation at about 55. You can see you get more ulnar deviation than you do radial deviation. The other motion that we highlighted briefly with the elbow was supination and pronation. He's already in a pronated position, and then you can get almost a full 180 degrees motion, which is supination. Each of those are about 90 to, you can get about 90 degree of motion from neutral to supination, 90 degrees of motion from neutral to pronation, for a total of about 180 degrees. The other important thing when talking about inspection of the elbow is something frequently referred to as the carrying angle. The carrying angle is actually formed by the ulna with the end of the humerus, or the end of the humerus, I should say. And frequently it's the angle that is taken if you drew a line between his humerus and his ulna. It would form, and divided that intersection, you would form an angle. Frequently that angle is about 10 degrees. In women, sometimes it's a little bit more, at about 15. Sometimes if particularly in women, if they have an increased carrying angle, that's sometimes referred to as cubital valgus. Nothing that you need to know for now, but just so that you know, men have a little bit smaller carrying angle than women. When we get up to the shoulder range of motion, I think is very important because really the shoulder is one of the most mobile joints in the body, probably the most significant in terms of mobility. We talk about sagittal plane motion at the shoulder with flexion, and you can get about 180 degrees. Go ahead and Sal, raise your arm all the way up. You'll get about 180 degrees, and some of that is combined with scapular motion as well, but predominantly glenohumeral. You can bring your arm down, Sal. And let me have you turn about 90 degrees facing the other way. The other motion other than flexion would be extension. And extension is extending behind the body. Again, it's still in the sagittal plane, and we get about 60 degrees. If you have them turn 90 degrees this way for me, Sal. The next plane of motion, as I demonstrated at the beginning of the tape, would be abduction, which is a coronal plane motion, which is out to the side. And you can get about 170 degrees, almost full overhead motion in terms of abduction of the glenohumeral joint. And come on back down. Again, this is coupled with scapular rotation as well. Adduction is kind of a difficult way to describe adduction, but it's basically bringing the arm to the body. And you can describe it in this fashion, or more commonly, people describe it in the horizontal or transverse plane, which is bringing the arm across the body. And in terms of the shoulder, this is what we more frequently refer to as adduction, although both motions truly are adduction. The next are rotation. Rotation is a little bit complicated. There's different ways to evaluate for rotations. I personally do it with the elbows at the side, with the elbows bent to about 90 degrees. And then what I frequently ask the patient to do is to try to act like their arms are gates and to externally rotate their arms as much as possible. You can see that he has about maybe 30 or 40 degrees of external rotation in this fashion here. The next way to evaluate would be, the next plane would be internal rotation, which is again a transverse plane motion, bringing the arm to the abdomen. Another way of checking internal and external rotation would be to have the patient put their hands behind their head. So Sal, let me go ahead and have you do this. This is a combination of motions, which is really abduction of the glenohumeral joint as well as external rotation. So that's one combined motion. That's one way to check it. Another way to do it would be to do internal rotation with adduction, and that's by bringing your hands behind in the handcuff position, so to speak. So Sal, why don't you go ahead and turn around for me? If you can bring your hands up on the small of your back. So this would be adduction and internal rotation, which is again a combined motion. The last way that I evaluate rotation, come on, turn around again for me, Sal, would be having the arms once again in 90 degrees of abduction. And I think this probably is a good way, particularly with the patient supine, is having them lay down. You've stabilized their scapula in this position, and you can have them do internal rotation, kind of like the scarecrow position. Be careful, because sometimes this has caused pain in patients who have impingement syndrome, something you will learn about as a clinical diagnosis, as well as external rotation. This also can be somewhat concerning because if people have an unstable shoulder, you can cause them to have increased symptoms with this. So internal rotation and external rotation is another way that you can do this. We're going to carry on next with screening examination of the spine. I think just to model this similarly to the rest of the physical examination, we want to do the same things, which is inspection, palpation, and then range of motion, and then any specific tests that you're going to learn in later labs. So for the cervical spine, we're going to start out by just inspection, and really you're looking for any gross atrophy that may occur. Again, when you examine things, you can't really examine them interdependent of each or independent of each other. They seem to be related. So although the scapula is here, I may look for atrophy of his rhomboids or his trapezius or any of the rotator cuff musculature that he might be having. When we look at the cervical spine, one thing that becomes fairly obvious, especially when you have patients bend their chin to their chest, I'm going to have Sal do that for me, and what becomes very prominent is the process of the spinous processes of C7, and that's very pointed out here as and highlighted as a very bony prominence here. You can go on and palpate T1 and T2. Some of the spinous processes, most of the spinous processes are fairly well easily palpated in the spinous or in the spine. And then Sal, let me have you bring your head back. As he extends back, go ahead and extend your head backward. You go into more cervical extension. And here you're going to lose some of those spinous processes just because of the position and the anatomy. Go ahead back to neutral there for me, Sal. The next position would be side-to-side motion, which is where I have the patient take their ear and touch their shoulder. And the thing to watch out for is sometimes patients, particularly in older patients who have some arthritis of their cervical spine, they may want to compensate by elevating their shoulder or scapula up to meet that. And that's really not lateral motion. We're looking purely for side-to-side motion. This, again, to review your plane, is a coronal plane motion, whereas flexion and extension is more a sagittal plane motion. The last motion that we want to look at is rotation, and that's where I have the patient bring their chin over as far as they can over their shoulder. So for Sal, he's got pretty good. He almost obtains full 90 degrees. I'd estimate that at about 80. I'll have him compare it to the opposite side and go to the opposite side. Again, always comparing it to the opposite side. That's why we have two of them. Come on back to neutral there, Sal. So those are the three planes of motions in terms of the cervical spine. The next thing would be to go down to the thoracic and lumbar spine. Thoracic spine is fairly interesting in the fact that it has very limited range of motion. And the reason why it has limited range of motion is because of the orientation, if you remember from anatomy, of the facet joints, or the zygoapophyseal joints. These joints are what helps articulate each portion of your spine together. In the thoracic spine, the facet joints are oriented in a coronal plane. So that means that motion through the thoracic spine is fairly limited in terms of flexion and extension. And in fact, one of the best motions that you're going to get is side-to-side motion. So I'm going to have Sal bend in the coronal plane side to side. And you're going to see that he gets good mobility in the coronal plane in lateral flexion side to side. So that's an important thing. The other thing to highlight with the thoracic spine is it also is the origin of the ribs. So we're going to start out by palpating. Sometimes it's easier, particularly in robust or muscular individuals, to start out on the side and palpate a rib and then work your way more medially and posteriorly. As you do this, note the course of the rib, because the rib actually goes cranially as it goes posteriorly, and as it comes inferiorly and laterally, it'll then course. Turn around for me, Sal. It will then course back slightly upward again cranially. So it has kind of a downward and then back upward course. Go ahead and turn around. The other thing that you want to observe in patients, particularly in adolescents, would be scoliosis. And one way to highlight this would be to have patient go ahead in full flexion. So I'm going to have you bend over. Sometimes this is referred to as a skyline view, and I think we're all familiar with this going through school examinations. And basically what you're looking for is that the curve of the spine is very much in the sagittal plane. If you see any coronal plane, which is side to side, as well as abnormal rotational motion, we sometimes refer to that as scoliosis. And you would see that sometimes indicative of one shoulder being higher than the other. So somebody might come in and they'll have a scapula that looks like this, may indicate to you or be a good screening test that they may have a spinous scoliosis problem. Go ahead and stand back up for me. Moving our way down, move into the lumbar spine. Some of the things that you want to do in inspecting the lumbar spine will be looking for something called a fawn patch or a tuft of hair. This is significant in some patients because it indicates spina bifida. And usually when you just have a small tuft of hair, that may be a spina bifida occulta, which means a little defect in the posterior arch of the spine. The motions that occur through the lumbar spine are once again flexion. Go ahead, Sal, and bend forward for me. The orientation of the facet joints in the lumbar spine are in the sagittal plane. So most of your flexion and extension is going to occur through the lumbar spine as opposed to the thoracic spine. And then we have Sal bend backwards and extension, once again noticing how well he excurses very well through the lumbar spine and the extension. The other plane of motion is rotation. And rotation is a transverse plane motion where I'm going to have Sal just rotate his arms side to side. And this is rotation that's occurring through the lumbar spine. Somewhat limited, but not as limited as coronal plane motion. And I want you to pay attention to the lumbar spine down here and just have Sal bend side to side for me. Come back to neutral and just bend in the coronal plane. That's lateral side flexion. You're going to notice that once again most of that motion occurs through the thoracic spine. His lumbar spine doesn't bend that much in the coronal plane. Let me have him come to the left side just to get a comparison. And you can see he does that fairly well, but most of the motion's occurring in the higher lumbar and thoracic spine. So I just wanted to review with you then kind of all the points that we talked about today. With physical examination maneuvers, go ahead and turn around, Sal. The things that really are important, I think, are to go through a systematic way of physical examination. With each thing that you do, I think inspection is very important. I tend to watch patients, particularly when they're dressing. If it's just their coat, it could be just their shoes and socks, but it really will give you a general idea about their function. Number two, we talk about range of motion. And as I mentioned, function, just watching them will help you with the range of motion. Number three is final palpation, and palpation is very important, and particularly knowing your anatomy, because without knowing your anatomy, you're not going to know where each of these structures lie to palpate them appropriately. The next would be to do your planes of motion. Know your planes of motion so that when you describe them to your colleagues, they're very familiar when you're talking